Today we're going to review both endodontal disease and periodontal disease and their etiology. They're both separate entities and involve unique pathophysiology. This is a brief introduction, and there is much more to know about each of these topics. Dental pathology is common and an under-recognized cause of significant oral and sinus pathology, yet is infrequently taught in medical school or residency. Our aim here is to present the anatomy, imaging findings, and imaging of the infectious complications of endodontal disease and periodontal disease through a series of cases with plain films, CT, and MRI. Here we have a stylized diagram. The tooth is made up of the crown, a root, and a neck in between the crown and the root. The crown is above the gum line, this pink area, the gum line. The root is below the gum line, and the neck is in between. The crown is coated with tightly packed rows of calcium and phosphorus crystals within a protein matrix called the enamel. This overlies the dentin, which makes up a majority of the tooth. The dentin is live innervated tissue. Below the gum line, the dentin of the root is covered with a thin layer of cementum rather than enamel. Cementum is hard, bone-like substance to which the periodontal membrane attaches, or the periodontal ligaments. These keep the tooth in place within the bone of the mandible and maxilla. The central chamber of the tooth is made up of the pulp. Pulp is made up of soft tissue and contains blood vessels to supply nutrients to the tooth and nerves to enable the tooth to sense heat and cold. It also contains small lymph vessels which carry white blood cells to the tooth to help fight bacteria. The extension of the pulp within the root is called the root canal. The root canal connects with the alveolar ridge via an opening at the tip of the root. The tooth's nerve and blood supply enter the pulp from the alveolar ridge through this opening in the cementum. There are 32 teeth with 3 commonly used dental notation systems for counting. The universal numbering system is used in the US, which I have shown here. Here we have an axial volumetric image of the teeth showing how you would number each tooth. We start at the top right at number 1, the right posterior molar, and count upwards as we move to the left side, and then drop down to the mandible and count upwards as we move to the right. A helpful way to count, because people don't have their posterior molars often because they've had their wisdom teeth extracted, is to use the front teeth and remember the numbering for the front teeth. Here's some typical dental radiographs. We have a bite wing view in the top left here. This is great for looking for dental caries, looking for interproximal disease, which would be disease between the two teeth where the teeth meet. We have the periapical view, which is looking for the endodontal disease, which we'll discuss more of later. And we have a panorex, which is really not for looking at the teeth, but is more for looking for associated disease, fractures of the mandible, tumors. In this patient, we'll talk about each of these entities later, but we have dental caries with fractured tooth, an interproximal carie, large interproximal carie, another interproximal carie. We have some cavities which have been treated on several teeth, and we have loss of bone. The maxilla and the mandible, the alveolar process of each of the maxilla and the mandible should come up to the margin of where the crown is. But over time, with periodontal disease, you have loss of that bone, and we'll go over that in detail. So what causes dental caries? Really, it's the presence of dietary sucrose, sugar. And it's related to the frequency of eating without brushing your teeth. The absence of fluoride will increase your risk for caries, and having a low salivary flow rate will increase your risk of developing caries. Caries develop over stages. You start with a small calculus or dental plaque on your tooth. A dimple will develop on the outer surface of the enamel. This will result in an enlarging triangular lesion with an apex towards the dentin. The lesion will extend towards the pulp chamber. So essentially the tooth is being colonized and the tooth is being destroyed by the bacterial colonization. And eventually the bacteria will extend into the pulp chamber. Now this is a nutrient-rich environment and also anaerobic, which is great for the bacteria, which will cause endodontal disease. You will often get adjacent tooth involvement, which is called interproximal disease on the interproximal surfaces, the surface that touches another tooth. So here we have an example of several of these entities. We have a large dental carie extending to where the pulp is. We have a recurrent carie in someone who's been treated for dental caries in the past. We have interproximal caries, so one tooth was infected, one tooth was involved, and then the opposite side was also involved. And this would be what would be called an occlusal carie, a carie of the surface, the surface of the tooth, which faces up or down. We can see this on CT. We will have tooth loss, dental caries, and we can have interproximal caries, just as we can see on radiographs. Next, let's talk about how caries develop into endodontal disease, and the complications of endodontal disease are what we're actually often imaging. Caries will eventually result in microbial colonization of the pulp. You end up with a biofilm on the inside of your tooth. This is a nice anaerobic environment for the bacteria to grow and spread. Now your tooth cannot form a reaction to this infection. It can't wall off infections in the tooth. And because there's an opening at the bottom of the tooth, as we talked about, for the nerve and artery, the bacteria escape at the apex of the tooth and form a small site of what is essentially osteomyelitis within the bone. Here, the body can actually wall off the infection, or at least attempt to. And you'll end up with a lucency at the apex of your tooth. Essentially, the body can successfully wall off an infection and form a granuloma. And so sometimes you'll hear people talk about periapical granulomas or radicular cysts. Now, there's a continuum between periapical inflammation that occurs with an initial infection and eventual formulation of a periapical granuloma. And imaging-wise, it's often hard to tell whether there's an active infection or whether or not a granuloma has developed. All we see is a lucency at the tip of the tooth, at the apex of the tooth. Now, if there's clinical signs of infection, or we see periosteitis of the adjacent bone, or we see evidence of soft tissue spread of infection, it's fair to assume that this is an active inflammatory periapical abscess. If we don't see those signs, then we can't be sure. Here's a crop panorax, which shows teeth that have been treated for dental caries, but regardless, this pulp became infected, and the patient has developed a periapical lucency at the apex of the tooth, which is consistent with a periapical granuloma or perhaps a periapical abscess. Now, this tooth will need to be treated or this won't recover. And so to treat that, what they do is actually come in, drill out the root, and put in a piece of metal called a gutta percha. And slowly over time, these will resorb and become more normal bone. Here's a coronal CT of the face, which demonstrates a periapical lucency with cortical breakthrough. This can result in soft tissue spread of infection. We see another patient with a periapical lucency, probably infected bone, which hasn't been treated. This will need to be treated with a gutta percha, and this will slowly heal over time. Now, periodontal disease is a different entity. Periodontal disease is related to tobacco use, diabetes, can be worsened by pregnancy, and HIV is also a risk factor. Essentially, you can think of diabetes and smoking as damaging the microvascular supply to the gingiva, which impairs the host immune system and impairs tissue repair, and the smoking itself causes inflammation of the gums. Here we see bone loss. The alveolar process again should come up to below the level of the crown, and then what ends up happening is you have loss of attachment area for the periodontal ligament and the attachment of the bone to the cementum. This results in loss of teeth. Here's a coronal CT of the face, demonstrating again complete loss of the alveolar process of the maxilla, which would result in a wiggly tooth, and on this side a loss of the tooth in the mandible. Now let's switch back to talking about endodontal disease and the possible complications. You can think of spread of infection from periapical abscesses into the adjacent tissues, depending on where the infection is. If the infection is adjacent to the maxillary sinus, it can spread there, and in fact often does. Look for this whenever you see sinus disease. Infection can spread into the nasal cavity, can spread along the hard palate, can spread outwards into the face, can spread intraorally through the buccal plates, can spread into the floor of mouth, and can spread into the submandibular region and into the rest of the neck from there. Now these are the direct sites of spread. When thinking about how these infections spread from the end of the tooth into the soft tissues, you have to think about where the mylohyoid is attaching and recognize that the apex of the posterior molars extend to below the line of the mylohyoid. So periapical abscesses that are involving the posterior molars will be a submandibular spread of disease, whereas infections more anteriorly will result in a sublingual space infection. Here we have a case on axial and coronal CT of a periapical abscess with cortical breakthrough into the maxillary sinus, resulting in sinus disease. So this type of sinus disease cannot be treated by treating the sinus disease. This has to be treated by treating the teeth. Here we have a 61-year-old male presenting with fevers and right mandibular pain. We see coronal CT and bone windows, soft tissue windows, axial soft tissue windows. We see spread into the sublingual space, but not inferiorly into the submandibular space. We see a large periapical abscess with cortical breakthrough, resulting in a large abscess extending along the floor of mouth. Here we have a 58-year-old male presenting with left facial swelling for 2 weeks. We have a periapical abscess, periapical lucency, which is consistent with the periapical abscess, with cortical breakthrough along the lingual surface of the mandible, extending to the soft tissues as a large soft tissue abscess. Because this is fairly posterior, it's actually into the submandibular space, and we see the mylohyoid being displaced. Here on axials, we have the same findings. Large abscess, skin thickening, subcutaneous fat stranding. Next, we have a patient with extensive dental disease, and we see 2 adjacent endodontal abscesses. And we have this thin, benign appearing periosteitis, and also sclerosis of this segment of the mandible in comparison with the opposite side. There is soft tissue swelling on the right as well, and fat stranding. So this is endodontal abscess with associated periosteitis, and this dense area of bone we call osteitis condensans, or condensing osteitis, and this is essentially a form of osteomyelitis. Here we have a patient with extensive periodontal disease, endodontal disease, multiple caries, fractured teeth, presenting with hematogenous seeding of infection. This is a 55-year-old man presented with right arm weakness. Initial MRI showed multiple ring-enhancing lesions with restricted diffusion on MRI. Right frontal lobe, left posterior frontal lobe. The right frontal abscess was sampled and demonstrated fusobacterium, which is a common infection in dental sources. And so to treat this person's intracranial disease, you have to treat the dental disease. So in summary, we talked about caries and their natural progression in relation to the anatomy. We talked about endodontal abscess formation and periodontal tooth loss. And we talked about what happens when you get endodontal disease and how you can get direct spread into adjacent tissues and how that spread can be limited by anatomic boundaries such as the mylohyoid. And we briefly showed a case of hematogenous spread to the brain. Thank you very much for your time.